So I'm Hafiz, just to introduce myself, a research fellow at UQCCR and CIE Respond. And today we have Jack Cross. Jack Cross is a senior pharmacist with more than 10 years of experience in clinical infectious diseases. He's currently working at the Gold Coast Hospital. And without any further delay, I would like to invite Jack to present his talk today. Thank you.
Thanks, Hafiz. Hi, everyone. So I'll get into it. So the title of the talk is Antibacterial. And it's just this really indicated that we'll see quite often versus, the more bizarre. And I guess just to set the scene, it's where are we heading? So, this is ADS data that's looking at the overweight or obese trends in Australia, and I'm pretty sure it'll be the same more or less around the world where you're tuning in. But I think Australia is leading the world. And we are certainly becoming more overweight or obese. You can see that it's trend line in this group, and the obese group doing most of the heavy lifting there. This in 1928, they looked at the average male, and it was a 1.72 meters squared semi-kilo MD, and 90 years later, we are substantially improved on that. So, some issues that I'll try and sort of dart around because it would make for a very long talk is the acute critical illness and all of those pathophysiologies that you see there, although they were always intertwined with these obese patients, it does make them a bit murky. And I'll formally acknowledge up front that what we're coming to in terms of an evidence base for dosing in obesity is quite commonly low quality evidence in terms of evidence-based medicine practice, PK studies and small sectional studies, and it's always method by a lot of confounding. By heterogeneity, but we do our best with what we have. So we'll get into case one, which is a Veronica community case in immunogenetically compromised. A 39-year-old female, 188 kilos, and they presented to ED in the morning after getting vigorship overnight, and they had a single diameter episode the day before. So this status, part clinical history was that they're obviously obese, hypothyroid, recent diagnosis of AML, and they underwent induction chemo 10 days ago. They really shouldn't have left hospital, but had a family crisis the day or 2 days before and discharged against medical advice. And I think these are some of the complexities that happen with a lot of patients. It's not just plain sailing all the time. So in ED, you can see there that they're hypertensive, tachycardic, tachypneic, she's maintained stats, machinic, but other than that, everything was okay. And was shadowed for the older journey with Piptaz, Bobra, and Bako, and probably following most, at least our local guidelines, that would be well warranted, but we'll get into the dosing and some of the issues. So she's referred and accepted to ICU, and this is all very fortunate the way that you're involved or we were involved because we were just finishing up an ICU and the intensivist at the time said, I've got this patient used to sit there and we'll up. They're 188 kilos, they've given a Piptaz. What else, we think there's some other stuff challenging. How much extra should we give? And it's a question that I think we probably get a lot. And have to think to yourself, now and as we move forward, what would you do? Where would you go to find the answers to this info? Maybe you bullet from the top of your head. That's great. I think some of us will benefit from it step by step. So, before we get to individual drugs, I guess most of our consultants are always narrowly opinion and at a very close tally, you've got more, give more. And I guess it's a fairly reasonable mantra to take. The larger you dose until it's big tip. But most of us, some of us at least, would think you start at this average dose and just keep going up dose until you hit a level where your patient lies. But in reality, it's probably more like the graph on the right, and we see that dosing children is ramps up to nearly doses that we would use in adults fairly rapidly. And then it hits this line where you shall not go any further. And in mathematics and geometry, that's called an asymptote. And it basically describes the end of the behavior of a function. And it applies probably well to some of the antibiotics we're going to talk about. So what the asymptote, because milligrams per kilogram is per kg to a point, then I'm going to start another. So dosing, and why is this? Because dosing based on total body weight assumes that our ability to clear the drug and this catachrome increases in proportion of increasing size. And this is unfortunately not the case. They kind of max out. So commonly using total body weight cap, the dose will equal to higher dose as we move through into the higher grades of obesity. And unfortunately, the other equations that we can normally utilize around certain drugs, like using body surface area, have these drawbacks as well. So, they can commonly estimate too low a dose in an obese patient. So we are stuck. And, for better or worse, that's why we're talking about it today. So we consult the literature, and we get this wonderful comment, which is considered the upper limit of oral dosing in severe infections, which is actually a very good comment, I think, and we'll go through it as we go through the individual drugs. But it comes from this paper by many colleagues, and it's very rare that I have a paper that I think, is a good one-stop shop. You can go there, you can start there, and you probably find really good starting answer for most things. And they did initially released it in 2017, and they updated it at the beginning of this year to update it with a few new drugs and also updates. So it's definitely worth a read. So tackling the question that the attendance raised. So how much nutrition we give? So classify the patient. Are they actually obese? And we'll do that in a sec. Think about the individual drug. So what is the site of infection, and does the drug go there? If the drug doesn't go in CNS and you're trying to treat it with a drug, that's a poor choice. Obviously, we have to think about where these drugs go and if they're an adequate choice. And is that site affected by obesity? How is it dosed? So is it fixed, or are they going in is that and how do we know? Toxicity is again, is like, what is the therapeutic index of the drug? I'll start with beta-lactams just to set a setting as an example. Have a very wide safety index. And I think we know that from either being part of dosing patients inappropriately for a period of time and wondering, wow, they didn't get any toxicity. Or you could look at things like the DALI study where, this is an excerpt from it, at 50% of the time dosing interval, all these beta-lactams, they got this huge spread in concentrations across patients. And this isn't a linear scale, this log. So, if we're looking at piperacillin and we're thinking maybe if my eye's good, that's 500-fold difference in concentration. And that's just mapping exposures. And it's in terms of tolerability, it's much the same. So, we've got a fairly good wide safety index for some drugs, not for all. Is there any drug monitoring option? So although the evidence to do this is limited, we can get justification or assurance, and that is quite useful. And is it acceptable? How's it done? Timing, shoots in, turnaround time. And turnaround time for me means, is it clinically impactful or is it academic? They're both useful things. They inform us sometimes for the next action or building an evidence base if we're thinking about publishing. But unfortunately, the turnaround time is standard. Those changes is it empirical model assisted and formulation factors. So thinking about rounding or just being able to give it. Other patient factors, well, that's probably outside of what I want to talk about today. So we're going to classify this patient. So they're 188 kilos, 165 centimeters tall. They're BMI 69. So they probably fit way down here, certainly in this red part of this graph. And a word of warning is the BMI is not developed to aid drug dosing, nor do they use it in drug development dosing states, on the most part, because body composition is not considered, the size is considered some. but it does represent a fairly simple metric that we all know, and it just gives us an idea. The correlating percentage of body fat. Unfortunately, and this is a big unfortunate limitation, is that it doesn't capture all body phenotypes. So you can have very muscular, high weight people that by all means wouldn't be having a huge amount of fat, and that does actually cheap. They may indeed need extra dosing, but that is obesity. But a BMI of greater than 30 in children, it's way more complicated, and they use percentiles. And if you're, and then they have 95th percentiles classified as obese. Misclassifications also in children. So let's go drug specific. Let's actually talk about drug now. So this is where we go over this change in PK. So hydrophilic compounds. So piperacillin here. If you've got a whole lot of those, you probably got an LNA group. You probably got a chance that this is going to be hydrophilic, and it doesn't move into the fatty tissue. So it represents 10% of plasma moving into that. So that's a low amount. So the VPD of piperacillin, clearance of piperacillin is increasing in these patients as well. It has been all of this has been predicted to have suboptimal peptide levels in certain studies. So you definitely got some concerns there if you're looking at just PK. So I used to do a checklist. The site, is it okay? Well, it's probably this patient, if we're worried about sepsis in their blood, I think the dose is going to, the drug should be okay. How's it dosed? It's traditionally a fixed dose of some route, depending on what part of the world you're working in. And toxicity is wide. We've talked about that before. So TDM is an option, and that's going to vary on where you work, and the generators is going to vary on where you work. But some possible approaches, and this is supported in the literature, is 4.5 grams 6 hourly being, and some of us would have that as a reflex in our intensive care. TDM, obviously, and in the absence of TDM, consider column infusions because it does remove some of the variability that's seen. So you could take an approach empirically, particularly in critically ill. So real life, what happened? We used 4.5 Q6 IV to infuse, and we did some TDM. The patient at 48 hours had blood culture with pseudomonas aeruginosa, and they were staying but still on presses. So it's TDM, it came back at 96 hours and sufficient at 3.4. And that's fairly low. We were, you can see a bit higher of a level there. So at this stage, we didn't have an MIC, so we didn't truly know what we're going at. But we changed to a steep IPI, so continuous infusion just on that basis. We were keen to see the overall exposure improve. And after 24 hours at that, we another TDM level and at 80.1. We also knew the MIC at that point was 4, so it's a nice sensitivity. So where did you get some of this information just on the basis of some of that? If you could go to men at our sort of work at or if you've got access to Cooch's, it's really great. At a textbook of our microbials, and it's got in many of its drugs dosing any of these patients. So that's an excerpt from it there, and you can start your journey about which side. So moving through. So we'll go to drug specific Panko. How do we normally dose sepsis? Big picture. Anyone want to crack? Thinking about it in their mind, it's like, it's probably maybe milligram per kilogram. There might be something like a loading dose, and then maybe maintenance doses after that. So the loading dose, make a big very big because volume distribution is one of the key components of working out a loading dose, and things that impact this calculation are physiochemical characteristics of the drug. And they're all there. Binding sites, so tissues and protein binding, the partitioning to fat. So if it's very polar, it might not be very lipophilic. So obesity, total increased weight equals increase in adiposity, increase in muscle tissue, and generally this increases the food dip substantially. So it's not always linear, but we can expect that maybe we're probably now figure the dose. So that's in keeping with this calculation here. It's important to consider drugs that do not enter adipose tissue well, because if that's the case, then you're going to have to use some alternate weight descriptors, and that's where the realms of adjusted body weight and total weight outside of that are useful for calculating a loading dose. So we'll get in and main dose is just clearance. But obesity initially that will go up, but as they age, it's very common for those chronic diseases to kick in, and those associated with diabetes or something like that. Do see things like CKD also kick in, and that can impair clearance. So you have to balance that in the patient front. So drug specific, we're back on bank, and then we're back on day one. So we don't know this patient has a pseudomonas in their blood. So changing pay, there's lots of literature. It's quite confronting when you start reading it because it's different metrics and then different doses. But most report increasing BD clearance, and it's exacerbated by shifts in sepsis. Increasing levels of obesity, there becomes a lack of scaling. So we start to see that asymptote occur. So, you do have to get higher doses, but as you get more and more obese, you can more run that back, and as in a range. So dose capping might be appropriate. And that's what those studies have found. So to go through the checklist, it's all okay. Cystity is narrow, and this is, some of the showing that in graphical form. And first dose is probably matter because we need to get it up into this therapeutic window as early as we can. So that's sort of, you can either spend a few days getting there, or you can jump the fence and load and get there earlier. And that's probably important in sepsis. So TDM is an option, quite commonly available. I think most sites in Australia and overseas would have access to it. The turnaround times are very different. So, most sites that I've worked in, it's that day, but in Queensland, we can see that churn out to 7 days to get that result back. So that is going to impact what you can do in response to UI. Sepsis, so we need a possible approach of the loading dose, 20 to 25 milligrams per kilogram, can go up to 30. And this excellent report from the three bodies, one of them being the Australian, the American Society of Physicians, Pharmacists, and the IDSA, have a great criteria, and they recommend a maximum of 3 grams. I think that's certainly in keeping with what we saw when we went over that prior to this co-now. And then they also recommend using compute their maintenance dose, and there's a myriad of available online calculators that can help you with that. And they also make the point that the intensive therapeutic monitoring should be all in this patient. So all of those come through to the real life for this patient. We give a loading dose of 3 grams that originally charted as 2. And then a maintenance dose of 2 grams CED, because our hospital policy is max of that, starting 12 hours after loading dose. Tolerable. So another drug that it's problematic to dose in obesity, shows 2 straight per day. So what to expect in obesity is it's very polar hydrophilic molecule. It doesn't move overly well with adverse tissue. The checklist is pretty benign, even with much the same sake, and we have to be careful in dynamic patients. That's not how the switch. I would imagine. So possible approach is that we probably use 7 weeks per year, but I recommend using adjusted body weight here. And this adjustment is that 40% of the drug will move adverse tissue. So that's where that 0.4 comes from. And that's using the difference between your actual body weight and your ideal body weight to work that out. And that comes to 767 milligrams. And then you probably want to complement that with TDM using ADC calc, and probably aim for an HC of 80 to 100. If you get a CMAX, that can help you figuring out, if you get a MIC, that can help you with trying to fight CMAX. So in real life, we increase the dose to 700 and 440. Also, the policy is that we should only ever use 700 as a top dose. And then the ADC monitoring it to 8 others came back at 74. So it's a little bit low, but we continue on daily with 700 daily every few days. And this is just one of the online calculators you can get to work out your adjusted body weight, which for this patient is 109. So that's the 3 guides. And now we'll move on to case 2. Case 2 is vancomycin isn't working. It's a 24-year-old female who's currently in our intensive care at GCUH. She's 205 kilos. She was at Blue A and aggressive MRSA pneumonia. and she was an FO retrieval from Northern Queensland. So the idea consult that was initiated on retrieval was that we should be starting letters in Antibacterial if she'd been on back in 2 weeks since deteriorating, and the levels were fine. So, that does happen. And we've gone through a different approach. She's sort of BMI 65, and then what to expect in terms of PK. Well, Mesolit is lipophilic, and it's got this large variability of its patients. You see ADCs in good sites ranging from 57 to 871. So again, it's quite light variability in what your overall exposure would be. And lower concentrations are noted in obesity. Captarally, well, the best we have is PK modeling. And for MRSA, you might need to consider giving it 3 times a day instead of twice, which is the standard. That does change depending on what we're targeting in terms of the body. Ignore it, but not in real life, because that does, you've got sequestration into the circuit, which does pose a real issue, but we won't focus on it for this talk. So the checklist, both of these drugs get into the lung. Dosing, it's fairly fixed, they're fairly fixed doses, but you can flex them if you need be. You can give part doses, you can give them more often. So, you could make it up and you could model it if you have that capacity. TDM letters has become commonplace, certainly where I work, and we use targets of the same 2%. You effectively should be doing them seeing our targets for that as well. Captaril is not so common, and I wonder if there are research as we reached out to a few sites to see, but we're unable to get that recently here. So in real life, we did it 12 hourly to buy drugs because that's the way the tradition made us, and that was obviously on Saturday, Sunday. There's all things happen on Friday and Saturday. Ongoing compromise on Monday, and we did a drop level and then increased both drugs on that on the spot to 8 hourly. And we did 2 levels at 48 hours into linezolid, but we didn't get it back for 5 days. It was 0.5. So if we using it semi target at 2 to 7, we all were fully under, and there's a range of things contributing to that. So it was reaffirmed why we went to 8 hours, and we rechecked that level, which came out 7 days later, and we got to 2.02, so barely to target. I can tell you that subsequent to this, I went on leave and had surgery, and I've looked back at the levels then when I got back yesterday, and she banded around below therapeutic on the 8th hour. So potentially we need to go higher, but thankfully we got rid of her. So we'll go to another case, which is slightly changing dynamics from the most acute unwell to the worrying well, and those who are unwell as outpatients, but they matter too. And this is a 45-year-old male, it's 144 kilos, and he's got actually osteomyelitis, like his right ankle which got caught in the brakes of his car, and I'll explain that sandals for our overseas listeners. In Australia, we call them bolts. And he's refused admission here because I think, talking from purely our lens of the world, most of our consultants will normally try to treat acute osteomyelitis with a period of intravenous therapy. That wasn't going to be the case here. He's growing in Staph aureus, someone sensitive, and he's anaphylactic to penicillin. Comorbidities is he's got a grip-on phobia of an IV line insertion and IV therapy. So much that he's quite threatening to staff if they start talking about. He's diabetic, high cholesterol, he's got non-alcoholic fatty liver disease. He's had a GI bleed relatively recently, 6 months ago, and he probably associated with his diabetes as well as gastroparesis. There's no for that. So the idea physician at the time wanted to do 6 weeks of oral ciprofloxacin when there's a justice there. And I thought doing clinic, and I was like, oh, it's pretty big. I'm thinking maybe we should do some TDM. And I'll be honest, the idea physician at the time was like, oh, I don't know if that's warranted. I think we'll be okay. But then he gave in. And, the first level come back was rifampicin, big trough level, and it was small. So immediately we thought it was a big waste of time. Everything's normal. We can just dose that as it is. We did give it high dose and, the standard probably, but the literature is quite scarce in terms of the ideal dose for that one. And a few days later, we got ciprofloxacin, and the ANC is low. So we're at 125, 250 HD, and it came back, I think, in the 80s. And that's on probably the bigger dose of cipro that we would normally use. So, that one we were reading out clinic, and we thought we'd just stop that from then. And so we had a bit of things for potential contributors, obviously. And we're thinking, is this oral absorption affected by some sort of delayed gastric emptying time? And there's definitely literature supporting that in the context of obesity. And also in non-alcoholic fatty liver disease, there's definitely literature also supporting production in metabolism across the board. So is that playing a role with a single part to 10%? We don't know. We also found out it was taking multivitamins at the same time as a cipro dose, which also plays into some absorption issues as they find out if there's a whole bit of calcium or magnesium in that. And it was formulation. So we made some changes in terms of dosing more often to have a cipro 500 TDS and repeating it so they kept that, and also getting rid of his multivitamin altogether. And thankfully, he only to repeat level 6 with cipro. So these are something to think about in the cases where you're outpatient. The same patient came back and returned to hospital for a skin flap over the area because he had quite a defect. And he was reviewed in the surgical pre-admission clinic by a pharmacist in the United States. And what we know, why did they review this patient at the beginning, or what was the lens of the focus, was that we know that there's an increased incidence of soft tissue infections and surgical site infections in these patients, and they also occur at a higher rate. So Cahazalan is, our workhorse in like a real surgical prophylaxis shown, and we added that standard approach at 2 grams, but doesn't well move into subcutaneous fat, it's psychedelic. And we also had a look at what the literature around this dosing that happen. And there's definitely, studies looking into doses size 4 areas. Getting used to primarily in the features. But so safety in those studies is quite good. So we thought, okay, what are we going to do? Thankfully, at least in Australia, we've got guidelines that support and recommend up to 3 grams EISC. We definitely chose to use that. Unfortunately, we've got Cahazalan and SARA drugs as well, antibiotics. Increasing the plasma levels doesn't necessarily increase your level of drug at site. So that may explain why some of the studies, although they're not great, have been looking into this. It's a 3 gram dose make a difference. It hasn't been that fruitful yet, but we'll hopefully see some better design studies in the future. This is very much an overview of all of those things coming. There's a bit of a checklist and reason why some of these drugs are moving. I'm not going to go through that, but if you're thinking about in cases in the future, just thinking about absorption, distribution, metabolism, and elimination, all the drug, you start to, hopefully it is pick up when you see, okay, this is going to involve obesity. And the bookend of this talk is that this is an excellent publication. If you start there, you're off to a flying start. So yeah, I can't recommend it. That's it. Any questions?